respected chairpersons, my teachers and seniors and friends. When we see acute multiple ligament injured knee, that means we are actually talking about a dislocated knee which has spontaneously reduced, and the patient comes to you in the emergency, you examine, there is a multiple ligament injury, but actually you may not appreciate that it is still dislocated. So I was looking in the literature in the PubMed, if you write acute multiple ligament injured knee, so that means we are talking about a dislocation of the knee which has spontaneously reduced, but X-ray might still show that it is still subluxated or still it is dislocated. Now this injury is not a new injury. As back as in 1825, Sir Astley Cooper, he mentioned about this injury. It is very rare as per the literature, but the true incidence is underreported because many of them, they get spontaneous reduction and they do not land up in the hospital, so injuries gets unreported. Now, 50% of these injuries, they are actually caused by road traffic accident, and amongst the rest of the 50%, majority is by the sports injuries, which is a low energy, and the rest of them, they are by spontaneous falls, which are mainly in obese patients who, because of the heavy weight during the fall, whole of the weight of the body contributes to the multiple ligament injury. Now when we say multiple ligament, we know that the knee has basically 4 major ligaments, ACL, PCL, medial and lateral collateral ligament, but now in the last 10 years, there are 2 more ligament complexes rather, the posterior medial and posterior lateral complex, so they are also very important when we talk about multiple ligament injuries. So, what is the common presentation? Usually 2 of the 4 major ligament disruptions are there, and the commonest presentation is ACL plus PCL, and maybe one of the medial or lateral that is associated with it. About 5 to 15% they are open injuries, so we should treat them like any open injury. And whenever we see a patient who has landed in the emergency after an acute injury and there is a hyperextension at the knee joint, we must rule out a knee dislocation or a multiple ligament injury by doing proper examination and investigations. If there is a popliteal ecchymosis, again it should alert us about this injury. Any sign of avascularity in the distal part of the limb is an indication that there may be a multiple ligament injury which is associated with a vascular injury. And then again, a patient had an injury at the knee who presents to you with a common peroneal nerve palsy or a foot drop, it should alert you about the multiple ligament injury. And of course, morbidly obese patients who had spontaneous falls and you are unable to really examine their knees, you must rule out multiple ligament of the injury of the knee by doing the proper investigations. Physical examination, only a small percentage of them, they come like this, where the knee is still dislocated. I have only seen 2 cases in my career, but majority of them, they get spontaneous reduction and they usually come to you late. So if you find such patient where the knee is still dislocated, the first thing you should do is reduce the knee and re-examine the patient for neurovascular status. And after you have reduced, you should admit all the patients under your supervision for the next 48 hours for the serial examinations of the neurovascular function, because many of them might develop a vascular damage, especially in the next 48 hours because of the intimal damage at the time of the injury. Vascular examination, if there is an expanding hematoma in the popliteus fossa, or there are obvious signs of avascularity in the distal limb, so that is clear that there is a vascular injury, but we are comparing the pulses on both the sides. If they are unequal, again that alerts that there is a vascular injury. But if there is no vascular sign or symptom, then it is suggested in the literature that you go for an ankle brachial index if you have this facility. It's a portable ultrasound where you can see it in the brachial region and the ankle region, and then get a index if it is less than 0.9, so that is an indication for further investigation. About 20% of these patients, they present with a common peroneal nerve palsy, and it is usually common with a varus injury. While we are examining them, we should be gentle because we should not be doing overzealous repeated examinations which can further cause an iatrogenic neurovascular damage. And the routine examination is we should examine for the collaterals by doing the varus and valgus test, and then for the anterior and posterior ligaments, as we know that we have anterior drawer Lachman test, and for the PCL we have the posterior sag sign and the posterior drawer test. If you find that a patient has an external rotation and recurvatum when you lift the limb of the patient from the great toe, that is an indication of posterolateral complex injury, and then you should further investigate by doing a dial test and the other imaging modalities. So after the clinical examination, the routine imaging is X-rays, like in any orthopedic examination, very important. Then you can take the help of MRI, again, which is important nowadays. Almost in all the cases we should go for MRI and the other investigations as per the need and requirement. X-ray will tell us about if the knee is still subluxated or dislocated, and it will also tell us about the associated bony injuries, and that will help us in planning our treatment. The MRI is indicated for all the multiligamentous injuries because apart from the ligament, the injury to the ligaments, it also tells us about the health of the menisci, articular cartilage and other structures. And if you can add MR angiogram, so that tells you about the vascularity also. But we should not be over-relying on the MRI because it is well reported in the literature that the MRI does not specify full extent of the injury. It should always be read along with your clinical examination, especially the examination under anesthesia in acute patients. So this is the diagnosis under EUA. You may not have to specifically go for anesthesia in these patients because they are usually polytrauma patients. So any polytrauma patient going for any other surgery, please examine the knee at that time. Take this opportunity. After all the femoral and tibial nailing or plating, we should develop a habit of developing the ligamentous examination so that you are not missing those injuries and then not neglecting them. And before the preparation for surgery on the knee, you should confirm your findings which you had done before giving the anesthesia. Then you do examination under anesthesia, and you can take the help of the imaging also to get the stress radiography. Now classification is, this is a classification by the Schenck depending upon how many ligaments are injured. That KD1 means a single cruciate plus collateral, KD2 means both cruciates, and KD5 means a dislocation along with the fracture. You add the word C if there is an associated arterial injury, and you add the word N if there is an associated nerve injury. Now treatment, now the literature, there is ample literature that with non-surgical treatment, the ultimate outcome is not good. So surgery is often recommended for the treatment of these patients, and the goals of treatment, as we know in any other joint, is painless, knee, stability, range of motion and function. So treatment can be close reduction. In the emergency, as soon as you see the patient, the knee is still dislocated, go for close reduction and do not put a direct force against the popliteal fossa, and do not ever hyperextend during the maneuver of close reduction because you can cause a vascular damage or you can worsen the vascular damage. Now, after you have done close reduction, there can be different scenarios that there is an obvious ischemic limb after reduction. That is actually indication for emergency exploration. Or there may be another scenario where vascular examination is normal, but the limb perfusion is normal. So that calls for an urgent arterial study or a color Doppler, MR angiogram, and then further treatment according to that. And the third scenario can be the limb is well perfused and there is a normal vascular examination, but still it is recommended that in all those patients, you please keep them under your observation for the next 48 hours because some of those patients might have an intimal injury which will ultimately develop into a full blockade of the artery. So after the 48 hours, if you find that the limb has a normal vascularity, then you can be sure that there is no vascular injury. But if you do not want to admit them, now the recommendation is go for MR, angio or other vascular investigations before you discharge the patient. If the closed reduction is not possible, go for open reduction, and initial stabilization after closed or open reduction, it depends upon the stability after the reduction. If the knee is grossly stable, then go for knee immobilizer, and if it is unstable, go for external fixator. Casts and splints are not recommended in the literature because they hinder in the vascular examination. If you are using a knee immobilizer, so try to put a padding behind the upper leg so that the gravity does not act, and then the PCL remains in the reduced, like the knee is not subluxated posteriorly. If you are using external fixator, please take care in mind that you will be doing a definitive future surgery, so pin placement should be accordingly done. If there is associated neurological injury, usually exploration is done along with the treatment of the other ligaments, and then there may be a nerve which is actually normal, so you just keep it under observation. If it is partially injured or completely injured, then you may require a grafting or a repair. Prognosis of the nerve injury is not good. Complete recovery is seen only in 1 in 5 patients. Definitive treatment can be a tendon transfer or an ankle foot orthosis. Now the definitive treatment of these injuries, whether they should be treated non-operatively or operatively, there is no RCT in the literature.
Dr. Ravi, please wind up.
Yeah, but for the grade 3 and beyond injuries, surgery should be done. Non-operative treatment is with the brace, and operative treatment is go for repair for the peripheral ligaments and the reconstruction for the ACL and PCL. You can do it on the same sitting, or you can stage them. If there is a fracture dislocation, you reduce and fix the fracture and repair the peripheral ligaments and go for the reconstructions at a later stage. So complications can be stiffness or instability, compartment syndrome, and this is the algorithm, just a short half a minute. Closed knee dislocation, post-reduction, X-ray shows there is a reduction is there, and there is associated vascular injury, go for vascular repair along with the peripheral ligament repair. There is no vascular injury, go for MRI and examination under anesthesia. If there is injury to the ACL plus PCL plus MCL, in the acute setting, less than 14 days is known as acute setting, go for brace for the MCL, delayed reconstruction for the ACL and PCL. In the chronic setting, go for ACL and PCL. I am finishing, sir. This is the last time.
Okay.
I am finishing. ACL and PCL reconstruction and MCL reconstruction. And if there is a 4 ligament injury, acute, go for repair and delayed reconstruction. In chronic, reconstruction of all the 4 ligaments. Thank you very much.
Could you have a seat, please, Dr. Gupta? Thank you.
Now I invite Dr. Arvind Arora. He is renowned orthopedic surgeon from UK, having keen interest in sports injuries and hip surgery and stomach. Please come to the desk. Dr. Arvind Arora.
Thank you, Chairman, sir. Ladies and gentlemen and colleagues, I'd like to present this controversial topic of femoroacetabular impingement. To start with, this is our center in Cambridge. This is the University Hospital, deemed to become one of the largest biomedical centers in the whole of Europe by 2020. Through the lecture, I'll take you through the importance description with the clinical features, investigation, management, and outcome, and also the future of this problem. The secondary osteoarthritis is well established, and there is always a cause for it. We know that there are reasons like DDH, Perthes, coffee, trauma, and infection. But primary osteoarthritis still is an idiopathic cause. Although there have been many theories mechanical, genetic and chemical, which have been floated. And the recent study from Oxford suggests that there is a strong relation of cam and pincer deformities in the siblings, which suggests to the genetic origin of primary osteoarthritis. Now, the interest in primary osteoarthritis had been long established. In 1920, Sir Robert Jones had advocated chelectomy of the head of the femur for treatment of the primary osteoarthritis. There had been lots of papers trying to outline the cause, and like in 1975, there had been papers suggesting that there is certainly a different reason for primary osteoarthritis. If you see the publications, particularly in the region of hip arthroscopy and management of the early lesions of the femoral acetabular impingement, there was very few in late 90s, and it was the last decade which brought us most of the publications in this field. The most important of these problems was highlighted by Gans, who suggested that femoral acetabular impingement is the cause of early osteoarthritis in the hip joint, and it is commonly present in young individuals who are of sporting age group. Now, what is an FAI? Impingere in Latin means striking against something, and Gans described that FAI is a painful contact between the femoral neck and acetabular ring, which is occurring during the normal range of hip movements. The reasons for the impingement from the acetabular side could be protrusio, or retroversion, anterior overgrowth of the acetabular margin, and from the femoral side there could be femoral deformities, abnormal anatomy, and overuse and sporting injuries. Now, the typical three types of lesions that are seen in femoral acetabular impingement is cam, pincer, and mixed. So if we see here, the first one is a normal hip with a spherical head, but the cam lesion shows there is a impinging lesion which is formed and forms an increased offset at the head and neck junction, which is responsible for the painful causes during the normal range of movement in the hip joint. Then the second type of lesion, which is the pincer lesion, which is overgrowth of the acetabular margin. And the third one is the mixed, which is the most common of the FAIs encountered in the individuals. The normal radiographs are quite good in demonstrating these lesions. So a normal head will adhere to the sphericity of the head, and even in the lateral view we will get a good spherical head, whereas if there is a cam kind of a lesion, it can be easily demonstrated by an overgrowth at the head and neck junction in the AP, and most prominently on the lateral views. The classical deformity that is encountered in these young athletic patients is a pistol grip deformity of the proximal humerus. And if we see in the surgical dislocated hip, we see the same overgrowth in the region of the head and neck junction, whereas the head of the femur is covered with a good glistening cartilage. The other deformities, the other problem which is usually seen is the torn acetabular labrum, which you can see in the other picture there. And similarly again, the big osteophyte form at the head and neck junction, and which increases the offset in this region. Now the other kind of deformity is the pincer one, which comes from the pincer claws of the crab, and there we can see the pincer ends. Now this is a normal hip with a normal cover of the acetabulum, but on the right hand side we can see there is an over coverage which forms the pincer lesion while they are moving within the normal range of movements. This is a retroverted hip, and again the same pincer lesion can be demonstrated in this lesion. Now the clinical features that can be seen in these young athletic group of patients is pain in the groin. They usually present with a C sign, and that is how they will say that this is where the main pain is. And it has been associated with pain during the sporting activities or long sitting periods. There could be mechanical symptoms like clicking and instabilities. The examination is very classical. There is limitation of the internal rotation, and there is a positive impingement test. The other tests like Faber's, Ober's, and the anterior labral and posterior labral tests may also be present. The investigations are normal radiographs. Here again they are showing increased offset at the base of the head, and which is again clearly demonstrated on the lateral radiograph. In the pincer kind of lesion, we usually see the crossover sign, which can be demonstrated in the second X-rays. And MRI is ideally a good investigation to demonstrate the lesion along with the damage to the cartilage and the acetabular labrum. There had been this paper from Hustler who had pointed out that these lesions are usually within the 85 degrees of the head and neck junction, and the other investigation which can be done to exclude that the pain is just coming from the hip is doing an MUAN injection in a theater setting, which can be diagnostic for such kind of a problem coming from the hip joint. The goal of the surgery is to improve the joint mechanics, correcting the head and neck offset, getting the correct waist and correcting the retroversion, and at the same time addressing the soft tissue problems of labrum and the chondral damages. While progressing towards this surgery, we should be very careful about the blood supply. If we remind ourselves here, this was highlighted by Gans, that after the medial circumflex artery comes through the obturator externus, it travels through the base of through the neck and then enters the head as a main supply in the superior and posterior superior region of the head. The excision of the cam lesion can be done through open surgical methods, as can be seen here. There was a big offset which had been surgically removed, and a normal spherical head has been left behind. Now following this, we should also examine the labrum, which could be detached, and this labrum should be reattached as to create a normal anatomy before reducing the head into the acetabulum. The other method of treating these lesions is through hip arthroscopy. Now, it can be done in supine position or in a lateral position. We propagate the use of hip arthroscopy in the lateral position. Now, the approach is about 1.5 centimeters above the tip of the trochanter, and the second portal of entry is about 3 to 3.5 centimeters in the same region. So there's the trochanter, that's the first entry, and that's the second entry.
Could you please round up, Dr. Arora?
Sorry. So this is how it looks, and inside the acetabulum we see that there is a torn labrum along with peeling of the articular cartilage, which can be excised, and a microfracture can be done to assist the healing of the cartilage. There's again the acetabular labrum, which is being excised to the stable margin, and the pincer kind of lesion again can be excised through to create a normal hip, and which could be tested immediately on the theater session to see that it is not impinging and not abutting the labrum. There is limitation to the arthroscopy, especially the posterior lesions, the global pincers and significant pincers, for which the derotation osteotomy is the answer. There is huge evidence now to support the use of hip arthroscopy for management of these lesions, and a good outcome following these kinds of, there are certain publications from our center to propagate that the current, the management of femoral acetabular impingement is well tackled using hip arthroscopy. Thank you very much.
Thank you. Thank you, Dr. Arora. Please take your seat.
I now invite Dr. Ashish Babulkar from Pune, who has a keen interest in shoulder arthroscopy and sports injuries. He has conducted many workshops and contributed to many chapters and books. I invite him to give his talk now on recurrent dislocation of shoulder.
With the permission of the Chair, thank you Dr. Mohapatra and Odisha Orthopedic Association for this excellent academic CME. We talk about recurrent shoulder dislocation. Most of us understand that there are several factors that cause dislocation. Unfortunately, there has been an assignment that recurrent dislocation means a labrum tear. The truth is somewhere in between, where there is always associated weakness of the rotator cuff, there is some amount of ligament stretching, plastic deformation. There are proprioception issues that we don't understand so much about. So reality is there's a big continuum between several different factors. Unfortunately, over the years, what we've focused totally on is just a Bankart repair. So in short, the surgery along with the rehab is very important in getting a complete result, and not looking at only stoppage of dislocation as the end point is very important. Now, if you look at the patients that get operated for recurrent dislocation, are typically going to be the young males who've had a significant trauma to start with and have been dislocating each time. But apart from this, this is some suggestion from my side that we must understand that there are also other patients who are multidirectional instability patients, which we must never operate at all. We must also be careful about that uncontrolled epileptic patient who is non-compliant, who's going to be a challenge for the best of the surgeons. We don't have patients of secondary gain, we don't have the compensation in India, so we are fortunate that is not an issue for us. But also as a surgeon, as a treating doctor, you must be careful about patients who come in and say, I have dislocated 100 times, you just go and operate me, I will find my own solution. So those are rebel patients. You must be very careful because they probably will not comply with your post-op regimen. The athlete is again a completely different animal. I could do the best of surgery and he may never even go back to his sport. He will have his full range of movement. He will have no pain. He will never dislocate, but he will just not be able to achieve his own. So the mechanisms in an athlete are less understood even by the best of the surgeons as such. I've put in there females, not because of any sexual discrimination, but the fact is if you look back, there are hardly any patients who are female dislocators that we've operated on. The prevalence of dislocation in females is extremely rare. So if there is a female dislocator, go deep down, search for another cause, or there's a hidden problem there. So there are several factors that cause dislocation. When a dislocation occurs, there is no doubt that there's a labrum tear. The capsule, of course, stretches first, so there's a huge plastic deformation of a capsule. I'm not too concerned about the rotator interval. I completely neglect it, and I do not address that at all. The Hill sacks we know, but we must establish whether it's a true Hill sacks or a reverse Hill sacks. And I'm going to touch upon glenoid bone loss at the end of my talk. The reason I've bracketed rotator cuff in red is because patients who are elderly and dislocate are completely different because they are high incidence of a rotator cuff tear. So almost 40% in those above 40 years old, and it's going to be very difficult to assess them for rotator cuff tear because of their pain and apprehension. So keep this in your mind, and if you have a patient who's above 50 and dislocated, do please ask for an MRI. You will never miss it. Nerve damage has been under-talked about, under-reported, and there is a paper from England which said that they did EMG studies for all the dislocators and the incidence was 40%. Most of them did recover, but it would be very embarrassing if we went and did a surgery on a patient who's had an axial nerve injury. So the tests are very common. I shall not go into details on the test. The only thing I wanted to highlight here was in this test that you saw just now, you will notice, go back there, you'll notice that this apprehension test is done in about 30 degrees of external rotation. The conventional apprehension test is done in 90 degrees of abduction. When you get an apprehension at 30 degrees external rotation, this is a sign of anterior significant glenoid bone loss. Do not hesitate to ask for a CT scan. So X-rays have a good place in treating shoulder instability, and it's my first choice of investigation. Because we are a tertiary center, I often get patients come in and they throw their MRIs at me and say, I have a recurrent dislocation, and then no X-rays done, which is incorrect. X-rays have a lot of story to tell, so my choice of X-rays are true AP, striker notch and axial for every dislocator. MRI, of course, will delineate the findings very nicely. Usually we would expect a 1.5 Tesla MRI. Here, what you're seeing here is a 3 Tesla fantastic image. You never need a God contrast with a 3 Tesla MRI. You can see all the 3 ligaments very nicely highlighted, SGHL, MGHL, and IGHL. Pune, we are favored because we have 3 Tesla MRIs of very top quality, so it gives us very good imaging. But a CT scan has a very important role to play, and if you give me a choice of only one investigation between an MRI and a CT, I'm going to pick a CT, and I will go ahead and justify that later on. So let's look at these X-rays. This is a normal axial X-ray, and this one you'll see an anterior bony Bankart. The bony Bankarts are dangerous. They must be treated soon because they will dissolve and eventually lead to a glenoid bone loss. You can sometimes see that on the AP X-ray as well. Here you are seeing an axial X-ray. This is a normal one, and here you can see that the anterior glenoid pillar is missing. There's a deep slope here suggestive of a chronic dislocation leading to anterior glenoid bone loss. So X-rays tell a lot of story. To the untrained eye, both these X-rays will look normal, but now if you look closely here, you see a nice cortical line along this normal X-ray, and if you look here, the cortical line is present only superiorly. Inferiorly, there is no cortical line. This is called as a double cortical sign. Now this is a high index of suspicion for anterior glenoid bone loss. So Gerber and Jankowskas reported that in 2010. The reality is Tamai had already reported in 92 and they were just reinventing the wheel. So it's all been there, it's only not been highlighted. It's a very important, simple, cost-effective X-ray that will tell us whether there's anterior glenoid bone loss. How soon should you operate? Wait for the range of movements to come back. Don't rush in when the patient is stiff, painful, and inflamed. So we must restore the range of movement satisfactorily. If there's a nerve injury, you must wait for the entire nerve injury to recover, prove it on EMG that it has recovered, and then move forward. If there's a rotator cuff tear, then you would want to go in a little early, not wanting to get that cuff tear to become large, irreparable, or wasted. The arthroscopic technique is now well accepted universally as the first line of treatment for recurrent dislocations. I prefer doing it in the lateral position. You are seeing the scope from the anterior superior portal. This is the labrum that has been stitched with a knot pusher here, and you can see a nice big bumper coming in there to bolster the glenoid anteriorly. But the point I'm making here is an examination under anesthesia is absolutely crucial and mandatory. When you put in a scope and put in all the fluid, and then you remember, you can't come out and do the examination under anesthesia because the fluid changes the soft tissue tension. As a rule, we will always do an examination under anesthesia because in the awake patient, because of the apprehension and guarding, you'll never get the correct feel. Now, this is a arthroscopy of a recurrent dislocation. You see no labrum here at all. So this is an ALPSA. The glenoid is bare, naked. The anterior labrum has fallen through anteriorly and medially, and you can't see it from the posterior portal at all. The same patient, this is after the repair. You can see a nice big chalk block, a good bumper. Do not think that the bumper is a physical restraint for preventing the dislocation. A good bumper means lot of tissue that will provide proprioception for the reflex contraction of muscles. So the labrum is not adequate enough to stop it in physical, as a physical restraint. Coming to the bony bankard, which is a completely different ball game, if you look at this X-ray, you can see there's something happening there suggesting that there could be a bony fragment there, and the X-ray is not enough. So you do a 3D CT, you must have a multi-axial CT scan, and you can see a big bony bankard there, and this is a rather impressive bony bankard. So unless and until we do a 3D multi-slice CT scan, we will never get to see this. This is post-surgery. We will do a CT scan 3 months after all of these patients to confirm that the bankard has healed with the bony component integrated, because you need the entire glenoid there structurally to be able to resume normal function as such. Now, Hill saccs is also a question, and there's been a lot of recent development, research and debate on the Hill saccs. The Hill saccs can occur at the first episode. It need not be a sign of recurrence. It's more a reflection of the velocity of trauma, really. And there's no issue about engaging and non-engaging, but there's a procedure called as remplissage, which means in French, just fill up the wine. So you fill in the defect with the infraspinatus by doing infraspinatus stenodesis, and that will obliterate the defect, and that is of my preference. But you must know when to do it. So we get our CT scan people to measure the defect and tell us if it's only 20% or more, would I do a remplissage, which is like 1 in 5 cases. Sometimes the defect is a hatchet defect, and the remplissage is not adequate for this, then we will use a osteochondral graft. So we use the femoral heads from our hemiarthroplasties that have been discarded by our colleagues and use them as allografts, take out a sector that matches it and fix it with a screw there. Now, to show you the difference, this X-ray series is not relevant to the topic, but I just wanted to impress upon you the importance of the CT scan. This is a lady, 50-year-old, fell off the stairs and heard a pop, and then she was normal, and this is her X-ray, but she wouldn't let us touch her, she wouldn't move her hand, and she had no pain. If you look at her, there seems to be a fragment there, and that seems to be a bony bankard. On a conventional axial CT scan, that looks like an undisplaced fracture, and you would, as a reflex, say that, oh, I would conserve her and she's 50 years old. Until and unless you do a sagittal CT reconstruction, subtraction of the humeral head, you will not realize how impressive that defect is and why we should go in and fix it. So that is why when you have a choice, ask please for a CT scan, which is a multi-slice CT scan on a sagittal reconstruction. We do measure bone loss, and this is on arthroscopy, anterior superior portal. That is the bare spot which is far to anterior. You get a very small anterior column, a rather large posterior column. So actually put a calibrated probe and measure both the columns. That is the most effective, reliable way of measuring anterior bone loss.
Can you wind up, please?
The last 2 slides. So that is the method that we would actually measure. The last 2 slides for importance of the Latarjet, because if you have 20% glenoid bone loss, it is important that you do a bone reconstruction and do not rely on the bankard. And this is what we do as a coracoid osteotomy, swivel it around and fix it with 2 screws. And that is the robust fixation. This is one of the gold medalists at the Cme Military Academy, And this is a recent, in October, Hindi Kesari Amol Bharati, who got his Hindi Kesari title after arthroscopic Bankart in 2009. So, in conclusion, you must treat instability soon. You don't need to treat the first time dislocator, but if he's had a second dislocation, he deserves an arthroscopic Bankart sooner the better, rather than wait for the bone loss to occur. Must identify glenoid bone loss. I think the arthroscopic Bankart has been universally accepted as the gold standard, but if you have a big bone loss, then feel free to do a Latache. Thank you very much.
Thank you. Dr. Tanna, please. Please kindly grace the... Dr. Tanna, Dr. Ravi Gupta. The session is now open for discussion. Any questions, please?
Mic is not working. Hello. My question to Tanna sir. Sir, since this is an academic session, in shattered diaphyseal fracture, can there be another modalities of treatment like primary or secondary biological plating? By secondary, what I mean is put the patient first in external fixator, then 3 to 4 weeks when there is sticky callus, do a biological plating. Whether can there be another modalities? Sir, you are a master of interlock. I think can there be?
Yes, I think I'll agree that plating is one of the excellent choice, but I'll not agree with your concept that put an X-fix first and then do a plating. I think even in a compound fractures, unless it is infected or old standing or a few days old compound fracture, you can do a primary plating after debridement. Plating is a wonderful operation. Probably, as you said in a conclusion, I said, instead of a nailing of such a comminuted fracture, probably the plating is a choice. Biological plating is a choice for me.
Thank you, sir. Thank you, sir.
Sir, to Tanna sir, it's a pearl of wisdom from you. Plating is important for such fracture which are segmental. When you say segmental fracture, the blood supply intramedullary is already jeopardized, and when you plate these fragments, periosteal blood supply is also jeopardized. I'm talking only on those bases because your wisdom, your practice makes it to prove that it has been. In this CME, is this a point of message which I confirm from you that intramedullary compromise can be taken by a good biological plating as a message?
I would still say the biological plating probably is the best operation for this, all these comminuted, really shattered bones. I think it is overemphasized that the intramedullary supply is gone, you put in extramedullary things. Every time you do a non-union, if it is a nailed which is a non-union, we go ahead and do a plating. And where does all those theories come into picture? Even if in a plating, the vascularity is jeopardized, it's only temporarily, and in a very short time it is a hypervascularity which comes, and with this biological plating which we talk about now, it is always a much better option. But in the days when we didn't do biological plating, the fractures didn't go into non-union all the time. If you stabilize the fracture, the vascularity is going to come back, unless you really take away the muscles. So even if you stabilized it openly, see that the muscle which has been dissected out is a very small part of the muscle where you want to put in a plate. And then the vascularity is not the issue.
Can I extend the same question, sir? When you do a segmental fracture, it is commonly seen when you nail it perfectly, one segment, the one part of the bone doesn't unite or takes delayed time than the other one. In such situation, is biological plating better because devastation has taken both ways? So which one would you comment upon, nailing better option in such situations where one end takes place earlier than the delayed ones, the other one?
Still in a segmental fracture, my choice is still a nailing, if it is nailable. Why it happens is, segmental fracture is, one fracture is in the isthmus. Second fracture is away from the isthmus where the medullary cavity is expanding out. The second fracture, the stability of the nail is not very good. while the isthmus fracture always heals up, because where the stability is very good, while the fracture which is lower down, where the medullary cavity is expanding, that stability is not very good. That part, if it is not healing up, I will go ahead early, put in a bone graft and put in a side plate in order to improve the stability over the nail, and probably that is the one which will help. I would not still think of doing a biological plating in a nice, good segmental fracture, which is not comminuted. If it is comminuted, obviously biological plating is the treatment of choice for me.
My question is to Dr. Ravi Gupta. So if all the 4 ligaments are broken, which ligament you are going to repair first? You said ki I will repair ACL, PCL even in acute injuries. If it is a mid-substance tear, how will you repair in acute injuries?
No, I did not say that. In 4 ligament injury, we repair the medial and lateral collateral ligament within the first 10 days, and then some people reconstruct ACL and PCL at the same sitting, but I stage them. This is what I said, that I usually do them after, healing of the MCL and LCL, the patient has reasonable range of motion, and then I go for a secondary ACL and PCL reconstruction. Sometimes if it is an isolated ACL or PCL, not both of them have 3 ligament injury, you may not require actually the second surgery.
Sir, question for
Question to Mr. Arora, please, regarding femoroacetabular impingement. What's your experience? Have you been trying it for avascular necrosis in young adults after the avian process has, died down? And then we see a lot of impingement. It's both the cam as well as the pincer. Have you done any in Cambridge?
No, basically these are young athletic patients with no avascular necrosis. These patients have had lesion.
That I understand what you have shown.
Yeah.
But have you extended the indication to burnt out avian which are not yet ready for a joint replacement?
No, not really. These surgeries, like what I showed here, is for removal of these defects, but if the avian has already set in, it is difficult to manage arthroscopically. The best treatment that we do in that case is core decompression with bone grafting.
We have used it for avian after the disease has run its course and it's in the reparative stage, and we have femoral as well as acetabular side impingement, and we have done several of these with very gratifying results. Thank you.
Great, thanks.
So in case of recurrent shoulder dislocation, glenoid bone loss of more than 20%, whether you will prefer open letarget or arthroscopic letarget, sir?
So I think the majority choice is open letarget. There are maybe a handful of surgeons in the world who would consider arthroscopic letarget. It's a very demanding procedure. We are doing it on a very selective basis, but I wouldn't recommend discussion on it.
For ill-sacs, you told about the femoral can be used for that. Whether that too will be open or arthroscopic?
Right. So that is reserved only for the hatchet defects. The round uniform hill sacks are usually treated with a remplissage. The osteochondral graft has to go in open.
Thank you, sir.
Dr. Gupta, you see quite often in a bumper injury with vessel injured, like the C-type one, what is your planning at point 1, at middle of the night, the vascular surgeon takes in, you fix it with an external fixator. How late you come in to repair the ligaments?
See, if it is a vascular injury and if there are any associated peripheral ligament injuries, I would like to repair the peripheral ligaments, that is the MCL or LCL, at the time of vascular repair. And then the external fixator is given for approximately 3 weeks, and then you remove the external fixator, give the brace, hinged brace, and start the rehab. And then you reassess after some time, once you get the reasonable range of motion, that you require anything to be done for ACL or PCL.
So along with the vascular surgeon, you go along for repairing the peripheral ligament?
Because otherwise you lose the chance of repair. Then you have to reconstruct those also. So if you do not repair the MCL and LCL in the first 10 days, then you cannot identify them and everything is jumbled up. you cannot repair them, then you have a choice of reconstructing them.
Generally-
If there are resource crunches, like your anesthetist says that he wants to, like the patient is not safe for further surgery, then I think that is the choice, that you can go for reconstruction of the MCL and LCL at a later stage.
Any more? I wish to thank all the speakers on behalf of the IOACON, and I wish to give a small memento as a remembrance to all the speakers. Please.
My suggestion to the organizers, as a speaker, we do not see the timer here. I think the timer, if it is facing us, then we can plan it out a much better way.
Then the time given was 15 minutes to us.
Yeah, and here this timing is for the audience, which is not really required. No, everybody were told 12 minutes.
The timer is.
Thank you for a wonderful session. We will be starting our next session. That will be decision making in adult reconstruction. May I invite the chairpersons, Dr. Basant Bora and Dr. Jiren Singh for the session. Dr. Ashri.
chairperson को देना
The chairpersons of the last session, they are requested to collect their mementos from Dr. Ashwini.
Good afternoon. Now it is my pride privilege to invite Dr. P. Suryanarayan. Please come for the presentation. Now we will have a discussion over adult reconstruction. We have 4 speakers. This is a pan-India representation. One has come from south, one from east, one from north, and one from west. Dr. P. Suryanarayan, he will talk on painful THR.
Dr. P. Suryanarayan, presently working as orthopedic and joint replacement surgeon at Apollo Hospital, Chennai, has presented many lectures all over and is a regular faculty in CME and workshops. May I request him to deliver his talk on painful THR. He is not here. He is not here. Okay. For the next speaker is Dr. J.A. Pachori, renowned orthopedic and joint replacement surgeon, Shalby Hospital, Ahmedabad. He has been worked with late Dr. K.T. Dholakia. May I request him to present his talk on osteolysis in THR. Dr. J.A. Pachori, please.
Yeah. Listen. Put the slide up. Yeah, okay. Chairman sir and my colleagues, greetings from Shalby Hospital. I am thankful to the Orissa Orthopedic Association for inviting me for CME, which is under my boss name, that is Dr. Professor K.T. Dholakia. The osteolysis is a silent killer of a joint replacement created by us, because this was never reported 40 or 50 years back. So we have created disease, and this is a particle disease. At present is an unsolved problem. This is one example of a post-op patient, and you see 17 years, complete massive osteolysis has taken place. These particles are very small. They are from 0.1 to 0.2 microns, and 70 to 90% of the particles are coming from the article surface. And the backside wear particles are large, they do not usually create the osteolysis. A metal cement, these are hard particles and they can create a third body wear, and these particles are responsible for osteolysis. We are still not able to separate these particles and which particles are making havoc of osteolysis. The debris is taken, these nanoparticles are taken by macrophages, they are phagocyte. This is one central example showing that particle is taken and you see a giant cell reaction all around. These are taken by the lymphatic system of our own body. If the particles are not very loaded, these are thrown out. If there is an abnormal load, the lymphatic system cannot take, and which stimulates the periprosthetic granulomas. And these particles have macrophages, they start producing cytokinin, interleukin-1, interleukin-6 and growth factor, and some of the newer cytokinins, which does lot of destruction, osteoclastic action, and start losing a bone. The osteolysis in a cemented socket is not that bad because there is a fibrous tissue at the bone cement interface, which acts as a barrier and does not allow destruction to take place. In an uncemented hip, the joint fluid passes at the least area of resistance, only the spot welding area which is not there, otherwise the massive osteolysis takes place, and it's called balloon osteolysis, which we see in an uncemented hip much more, which I'll show you on a few scans. Wear rate in cemented orthoplasty is 0.007 millimeter, but uncemented is very, very high. So we are actually worried about uncemented hips. The wear is very, very high. New highly crossed poly, which is all right in laboratory, but we still is not immune for osteolysis. The particle size are smaller, so we are really worried. There is one study going on with our own institute, and these are retrieved specimens from Dr. Dholakia unit, and we are working on the wear rate in our country with BITS Pilani, and we are still in the process. We have done about now 30 of these retrieved specimens, and we are working on what is the wear rate in our country. The diagnosis clinically is very poor sign. There are no much signs in the patients for osteolysis. Normal AP and lateral radiographs are not reliable at all. The best radiograph to pick up osteolysis is 45-degree iliac oblique and 60-degree obturator view. But today, the CT is a gold standard for looking at the osteolysis. It can give location, size, pelvic discontinuity, and this method helps quite a lot. And it helps in revision, and there's good papers coming up. The silent osteolysis is diagnosed almost on 49% on CT scan. So CT is very, very ideal to pick up the osteolysis. This is one just example of a plain X-ray. This is a 12-year follow-up of our own patient. Shows some amount of osteolysis on the supraacetabular area. But if I look at the CT scan, huge massive osteolysis taken place, and area of the spot welding, there is no osteolysis. So wherever the spot welding, the osteolysis does not take place, otherwise a massive osteolysis take place. So we'll discuss osteolysis on the femoral side and acetabular side. The femoral osteolysis classification is type 1, well-fixed implant, only metaphyseal lesion, and is usually extensive coated stem. Treatment, just take out the poly or debride and put some graft. This is just one example of a patient. This is a furlong hip. It is a well-documented 30 or 35 years follow-up patients, and this stem is usually good, does not require removal. Just take out the cup and the lesion in the proximal metaphysis will heal. And there's a 2 years follow-up of this patient. So there are two good papers coming from the series that shows that once you change the poly, the metaphyseal lesions, they do heal well. The type 2, a well-fixed implant, metaphyseal lesion as well as diaphyseal lesion. Diaphyseal lesions are not good because the chances of periprosthetic fracture during grafts are very high. So you will have to revise these stems. So they don't do well. The lesions which are extended down will not do well. And this is just one example of a proximally coated stem. It looks that it is a well-fixed implant. On a CT scan also shows this, but the track record of this implant is not good. So we got to revise this implant, and we took it out the implant. You see the proximally bone in growth, but this implant the track record is not good because you see the lot of metallosis has taken place, and this is revised hip at 2 years. So any metaphyseal extension will have to revise the stem also. Type 3 is a loose implant, so there is no question that you got to take it out, everything, put a new poly, put a good implant. And this is one example of massive osteolysis, remodeling varus has taken place, so we'll have to change both components. The trochanteric osteolysis, you have to have the new poly, trochanteric fixation, depends on the displacement. This is just one example of trochanteric fixations, 10 years follow-up. Now this lady will need a revision because you see a lot of massive osteolysis in the supraacetabular area, the wear rate, and it is going to be a very tough job for me to do the revision of this lady. Now pelvic osteolysis, in a cemented hip on the established side, the glide lines are extremely clear, but uncemented glide lines still are not clear. But we are agreeing now, a progressive osteolysis during 3 to 6 months every follow-up, eccentric polywear has taken place, and complete penetration, revise the hip as early as possible. Don't wait for pelvic dissociation. On a cemented side, I told you the guidelines are very clear. This is one example, post-op 1985. After 11 years, you see both sides, the wear has taken place, osteolysis has taken place. So we have kept the stem intact and just put the cups, both sides, uncemented cup, 7-year follow-up, and that's 12 years follow-up. So this is guideline